Okay, well, I want to thank everyone for staying with us this point in the afternoon. So I really appreciate you sticking around for the presentation. My name is Lori Uscher-Pines. I'm a policy researcher at RAND. And over the past few years, I've done quite a bit of work on direct-to-consumer telehealth. But we're also very interested in telehealth more broadly, especially as it applies to the underserved. I'm currently working on a project with my colleague, Ginny Kochis, looking at the impact of telelactation support on breastfeeding outcomes, and she presented that poster earlier this afternoon. So, a range of projects across the spectrum when it comes to telehealth. This particular study looks at the impact of direct-to-consumer telehealth on utilization and spending, and folks have talked about it a little bit so far at the meeting as well as at Matrix, so I'm enthusiastic that I have the opportunity to answer any questions about it and just to go into it in a little bit greater depth. I know you've had a little preview of it before. So just to orient you to RAND's research portfolio on direct-to-consumer telehealth, we've done a number of studies using CalPERS data. So the California Public Employees Retirement System is a benefits organization that provides benefits to over 1 million beneficiaries in California. And they offered Teladoc as a covered benefit in 2012 to approximately 300,000 enrollees in their HMO plan. And we have used this data set in a number of different studies. Here are some of our key findings over the past few years. Many of them have been very positive and have been used by Teladoc in its marketing materials, so a lot of good findings for telemedicine. We found that direct-to-consumer telehealth increases access. So in one study, as many as 20% of Teladoc users had not been plugged into the healthcare system at all in the year prior to the implementation of Teladoc. So clearly, these services are increasing access. We found lower follow-up rates for an index visit at Teladoc as compared to an index visit at other settings. So that told us, probably Teladoc was resolving these patients' complaints. And we also found similar rates of antibiotic prescribing. So some very positive findings to date. Direct-to-consumer telemedicine has many advantages, and chief among them is the fact that these services are so convenient, offer patients around-the-clock access to physicians on personal devices. And a lot of companies say that there's potential cost savings here because these visits can replace visits to more costly settings. But there's also this concern that these services will lower the threshold for seeking care precisely because they're so convenient, and that could lead to new utilization. And that's really what we wanted to test. Others have looked at costs on a per episode basis, and really across the board, we're all finding the same thing when it comes to per episode costs. The new thing that we're looking at here is really the impact of offering these services on substitution versus new utilization. So again, we use commercial health care claims data to estimate the impact of direct-to-consumer telehealth on spending, this same data set that we've been using in the past. So here are our research questions. First, are ARI episodes, so acute respiratory infection episodes of care that originate with telehealth less expensive than episodes that originate at other settings? Then does telehealth visits replace visits, or does it represent new utilization? And then, considering these two earlier research questions, then what is the overall impact on spending? So quickly to go over the methods, we had a telehealth user cohort of approximately 1,000 users, and we had a matched cohort of 2,000 non-users. In an ideal world, we would do a randomized control trial. Many of you are researchers, that's the gold standard. We weren't able to do that in this setting, so we did the second best thing, which is apply quasi-experimental approaches to our claims data. We used a combination of propensity score matching and then a difference in difference regression approach. And what the propensity score matching allows us to do is to create two equivalent groups that look the same on all factors that we can observe. So their age, their sex, how sick they are, if they have any chronic illnesses. And then what we can do with difference in difference is then try to account for any unobserved differences that we weren't able to design out with the propensity score matching approach. So we didn't make up these methods. These methods are used very often by health economists, and we've used them in the past to look at different innovations in healthcare delivery. So, a tested method of really assessing the impact on utilization and costs. So we defined an episode of care as the day of the visit and then 2 days after the visit. So here's our table 1 from the paper. And what you can see is that prior to matching, the telehealth cohort does look a little different than the non-telehealth cohort. I'll direct your attention to comorbidities. So the telehealth cohort is healthier, has fewer chronic illnesses, and they're also more likely to have no ARI visits in the year leading up to teledoc implementation. But after matching, the groups look equivalent, and that's something that we look for to make sure that our propensity score matching technique worked. So this slide goes into costs. So definitely an episode of care that originates at telehealth is cheaper than an episode that originates in the emergency department or physician office. And this is something that others have found. There was an article just a few weeks ago in the Journal of Medical Internet Research, found the same thing. Across the board, on a per episode basis, the visits are cheaper when you're looking 2 days out, 7 days out, 30 days out. And this just shows you, when you break it down by type of service, again, a consistent story: pharmacy, imaging, testing, all less expensive when the visit originates with telehealth. This slide just allows you to look under the hood with the diff and diff. And what I just want to show you here is that for the non-telehealth cohort, their visits to physicians' offices and EDs increase from 60 visits per 100 members in the pre-period to 87. So that's an increase of 27. In the telehealth cohort, however, there's only an increase of 17. And you would expect the telehealth cohort to look exactly like the non-telehealth cohort. So this allows you to really tease out the treatment effect. So it looks like there's substitution of about 10 visits here. However, there are 85 new telemedicine visits pre to post among the telehealth group. And from that to us is evidence of substitution, a minor amount of substitution of 10, but new utilization of 85. Sorry, of 75 new utilization. You subtract out this substitution. So what does all of this mean? So episodes of care that originate with telehealth are clearly less expensive based on this research, as well as some other research that's come out over the past couple years. There's some substitution going on. As I mentioned, those 10 visits represent substitution, but overwhelmingly it's new use. Because of this, spending per telehealth user is higher, about $45 per telehealth user, because savings from substitution is swamped by spending on new visits. And it's this piece of the analysis that's inconsistent with what others have reported. So the direct-to-consumer telemedicine companies typically report research that about 90% of the visits represent substitution to other settings, and about 10% represent new utilization, and this study flips that. So a number of important limitations. And Ativ and I have both been trying to educate reporters about this. There are a number of important limitations. Every study has limitations. This one has plenty of them. The first is generalizability. So we're only looking at direct-to-consumer telehealth for acute respiratory infections, so unclear how this generalizes to other conditions. There's also low uptake of telemedicine among this particular cohort, under 1%, which is similar to what you often see when payers offer these services. At the beginning, it tends to be fairly low uptake. Also, these patients had little to no cost sharing. You might expect to see something very different if patients had to fork out some more money to participate in these visits. There's also the issue of selection bias. So we used robust quasi-experimental approaches here, but we can't control for changing unobserved factors. So advertising, increases in awareness, those sorts of things that are time variant. We can't design that out. And then finally, we're not capturing other factors of importance to payers and employers. We're really looking at this from the perspective of the payer. But if you're an employer who wants to offer these services, perhaps this does have an impact on outcomes important to you, like productivity, absenteeism, and presenteeism. We didn't look at that in this particular study. So I think that the most important thing here is that we really do need to replicate these findings in other settings. So, this does not a body of literature make. This is just the first published study to really look at this issue of substitution versus new utilization. But we need to look at it in other populations with other conditions. But the fact that these visits are cheaper on a per episode basis tells me that there's really a pathway to savings. So there is a way that you can implement direct-to-consumer telehealth that doesn't necessarily lead to escalating costs. How could you do that? You could make the services less convenient. That's not particularly attractive, right? Because the whole idea here is that these services are convenient. But you could erect certain barriers. You could require patients to go to a symptom checker first, just require intermediate steps. You could increase cost sharing, which is something that I mentioned. When these services are more comparable to seeking in-person care or even more expensive, then that will have an impact on patients' decision-making. Finally, you could roll over in-person visits to direct-to-consumer telehealth visits. So take patients who are already in the waiting room, for example, who have already gone to the trouble of putting on pants, as we showed in the last cartoon, gone to the trouble to show up in person and introduce them to these services, and then really substitute an in-person visit to a telehealth visit. But in general, there are many strategies here, and I think that we just need to think creatively, even if we do see that these findings are replicated in other settings. Okay. Thank you very much for your time, and happy to answer questions.